unique insight. In our series, we use a chapter of Medjack as a springboard for our discussions, inviting panelists to delve into their journey in innovation, creativity, and entrepreneurship, which we like to call as ICE. Today, I'm excited to introduce our esteemed moderator, Dr. Asadnia, with his dual roles as a professor in emergency medicine and director of CCIT. Dr. Mia brings a wealth of knowledge and experience that promises to enrich our conversation. Moving forward, I'm honored to welcome our distinguished speaker, Dr. Anna Yaffee. I hope I pronounced the name right. An associate professor at Grady Memorial and Emory University Hospital. Dr. Yaffee is deeply involved in emergency medicine. She liaises with Emory's Serious Communicable Diseases Unit and contributes to the National Emerging Special Pathogens Training and Education Center, leading the Global Health and Emergency Medicine section and serving as the Director of Global Health Education at Emory School of Medicine. Her focus on public and global health is exemplary. Dr. Yaffee's academic focus on public and global health. Her academic journey includes an MD and MPH from the University of Michigan, and she has served as a lieutenant commander in the U.S. Public Health Services and an epidemic intelligence service officer at the CDC. Your insights would be very invaluable today. Thank you so much, Dr. Anna and Dr. Asithnia, for joining us. I leave the floor to Dr. Asad.
Great, thank you, Zanera, and an absolute pleasure being over here with Anna. And Anna, I've got to know, it's been a few years, knowing Anna through the American College of Emergency Physicians international section, and Anna is very well known in that group and globally as well because of her interest in global health and emergency medicine, and we'll get into that through this conversation. More recently, I had the opportunity to meet with Anna at Emory in Atlanta. That was just about a month back, and she led a conference over there. It was a Global Health and Emergency Medicine conference, and I was one of the speakers. It was a great session for me as well because I got to hear about a lot of things that are happening in other parts of the world. In fact, I think none of the speakers presented anything that was specific to the US, but it was meant to be global health. And so, but definite learning about not just the health systems of other nations, but the conversation, I think the discussion also led to a lot of understanding about the challenges and the opportunities potentially for innovation work in the US as well in emergency medicine, and that was my learning as well as things that I was picking up over there. So Anna, without further ado, let's just get into this conversation. And I think the first thing that I'm interested to hear about from you is your experience of working with Indus Hospital on the CPEM program, CPEM or CPEM, and you can tell the audience more about that and how long have you been working with Indus on that program, and then we can get into one or two follow-up questions. And also let us know what you think about Karachi, by the way, and be candid.
I love Karachi. Yes, I love the biryani. I love coming. I'm actually going to be there next time back. It feels like a second home to me. I have been working with Indus Hospital and Health Network for the last 5 years, I think, now, and it's been like a really rewarding experience. I got tied into the work there with the certificate program in emergency medicine, which is a 1-year training program for medical officers working in the emergency department space to actually kind of get trained up in specific needs in emergency medicine. It was started by Harvard's Brigham and Women's Hospital, and now is run kind of in concert with the University of Pennsylvania as well. So I first came as visiting faculty when I was actually a new faculty member at Emory, just taking an advantage of an opportunity that came through the ASAP International listserv, but I didn't realize that it would kind of create such a life-changing experience for me, very rewarding collaborations with colleagues at Indus, and has now jumped off into other programs, particularly a trauma team training course that we run together.
Yeah, that's great. Great to hear, because and I'm glad you kind of mentioned the trauma program, because you presented on that at the conference at Emory. And so, would you care to expand a bit further on that, and then perhaps link it to for people who are not familiar, the starting point of the conversation starter is a chapter from the book Medjack, and in case of for this particular webinar, we picked chapter 7. Which talks about Jugaar innovation, and I'll leave it to Anna to kind of explain to us what her understanding of Jugaar innovation is, and perhaps using her own project, the trauma project that I heard about, and if you could perhaps highlight some of the features that are consistent with Jugaar innovation.
Yeah, I actually found the chapter really interesting, all about kind of low resource, low cost innovations. And I think that a lot of what we do in emergency medicine, both at home and all over the world, is low cost, low resource innovation. And so I think it's like a very relevant topic in emergency medicine, and very topical, I think, for the times in particular. So the trauma program that we developed with colleagues at Indus Hospital and Health Network is called Collaborative Advanced Trauma Care, and it was developed out of a need, basically understanding that there's a lot of trauma, morbidity and mortality for patients in low and middle income countries, and in high income countries as well, for that matter, and shown to improve patients' ultimate morbidity and mortality. And so having a team-based collaborative approach to trauma is really kind of one of the hallmarks of a kind of adequate trauma response. Now, that's usually done in the process of utilizing trauma teams, which are teams put up between emergency medicine doctors, surgeons, emergency nurses, for example. And those teams work together with everyone serving an equal role, but distinct role. This concept bridges off of the advanced trauma life support framework for physicians caring for trauma patients, and the trauma nursing core course for nurses caring for trauma patients. But those courses are more focused on kind of the individual provider-patient relationship and the kind of actual medical care of the patient, whereas our Collaborative Advanced Trauma Care course, or CATC, is really focused more on the team building and leadership in caring for a trauma patient, and how to do that successfully together. So we piloted it at Indus in Karachi, I think in 2019, I want to say, was the first course. And since that time, we've actually expanded all throughout the Indus Health Network, as well as into other countries. So we've expanded into several hospitals in Vietnam, in Hanoi, Vietnam, and also at Addis Ababa University in Ethiopia. So we've trained over 400 which has been really cool. And now we've actually started a training of trainers, so we have our participation. So it's been really cool to hear. I get WhatsApp messages from past participants telling me about patients that they've cared for using the framework, and it's always so exciting to hear from them.
So tell me a bit more about this. The trauma team, I guess, process, and the way that you run it. So when you do this at different programs, and so you started off at Indus in Karachi, and then there's the Indus Health Network, and so you probably took it to other hospitals that across maybe not in Karachi but in the province, and then into other countries as well. What is the sustainability model for you, and do you think at times like just kind of doing this, is it like is it more like a one-off per hospital? And then what happens once you've done this and you've gone on to other hospitals? Something like this, I'm assuming that it requires a refresher course perhaps. And so who is that built into some kind of a sustainability model, or how are you thinking about scaling these kinds of things? Because I'm interested in such approaches from an entrepreneurship perspective as well.
Yeah, so we specifically select places that hospitals that we expect to have a long-term relationship with. And so when those hospitals are selected and kind of looking at their network and kind of their interest level in expansion, these are places that like really have a dedication to developing trauma teams, kind of developing education in this space. And so that's how we kind of chose based on these longer term collaborations. And then additionally, in terms of like kind of the sustainability model of people that actually have like kind of strong collaborations across their country has been very helpful. So actually we're hoping kind of as it becomes more, as we teach more and more of these courses, that the courses are self-sufficient in terms of training, trainers able to deploy on their own throughout their own networks. So for example, after a participant goes through the training of trainers, they will have they will teach a course with a master trainer, and then once they're kind of checked off in terms of their to teach, then they'll be able to actually teach the course on their own without external input. So with support, of course, remotely, but without anyone on the ground. So we hope in that way it's more sustainable. Going back to chapter 7, these are also like very these courses are pretty low resource. You don't have to have a state-of-the-art sim lab or state-of-the-art educational materials to learn. These are mostly like team building and interpersonal relationships that can be done with no money. And actually all of our simulations, our skills labs, all of these are based on a framework of using low resource models. So certainly we've taught in places that have kind of higher tech skills, simulators, things like that. But I find honestly that the low resource models teach just as great, if not better, than some of these like fancier sim people, for example. So you really don't have to have a lot to actually have a very fruitful conversation.
Excellent. Thank you for that. Right. So makes a lot of sense, right? So it's kind of gratifying to hear, from your experience that you're talking about low cost and low tech or low fidelity kinds of approaches, and based on your experience, these kinds of approaches, Jugaar innovation approaches, work equally well, if not better, than focusing on sim-based approaches. We've had a few speakers in our webinar series who are sim people, so they've developed sim labs, and so the way that they present those kinds of innovations, I don't think they delve into low-cost iterations of those mannequins or other kinds of tools that they utilize. It seems like it is definitely high tech, and it's costlier. Perhaps for a place like the Archon University, where we're housed, we have our own innovation lab, we have a sim lab, and we have a really cool sim lab. And so, but you're talking about a place like Indus and other hospitals similar to Indus in Pakistan, in Karachi, even for that matter, that don't have access to cooler technology. So how are you going to teach those folks? Have you published your approaches as your data from the trauma work of yours?
We we presented it at many international EM conferences, but you're right. The next thing we have to do is publish it. We wanted to have this last course in this month, and then the first quarter of 2024 is devoted to writing up all of our results and publishing it, because as you know, publication is really important to kind of disseminate findings and impact, and then hopefully set us up well for the next stage, and particularly kind of to assist in obtaining more funding. So writing is always kind of, I don't know if you find this, but kind of the most boring part of anything. So that's been my own personal barrier, at least.
Well, that's a great point, but from an innovation perspective, because I'm trying to like kind of look at your project, and I'm like looking at like synergies from an innovation, creativity, and entrepreneurship perspective, and they're definitely there. You just have to like seek them, and you start seeing those aspects in a research project. You've run it as a research project, right? An education project or an education research kind of a project. The reason for me asking about whether you publish your data is not so much, yes, it's kind of tedious in my experience. So the book came, Medjack came after we had published a few papers. So from the hackathons or from some other experiences of ours. And I think it was almost at times I was being forced to publish versus knowing that the interventions worked. We could show a great amount of learning through these alternative ways of teaching folks through a hackathon, for example. But when you are communicating with academics, I think they just expect that it has to be from a journal and a citation, and otherwise they won't like accept it. Do you? But if you think about like Jugaar innovation, so we're talking about innovation here, right? So do you think the future is still based on your work in the US, and is it still the currency? Is it still biomedical journals and papers and publications in journals as the end all be all, versus other ways of communicating or disseminating your findings?
Yeah, I think there's like a lot of other opportunities, right, for dissemination, FOMED, blogs, books, social media, things like that, which I think gets the word out. I think there is a place for publishing. I think the peer review process is really important to make sure that things were rigorously done, that impact was assessed correctly, and I think that unbiased review is really still useful, and I don't think it's going anywhere, but I think certainly there's opportunities in other spaces to share findings and to share impact. And I think that's great. I think that it should be both, right? Like we should have that peer review, we should have that checks and balances, but also we should be able to share kind of even more intangible impact, the anecdotes, the things like that are not as hard science, so to speak. I'm glad that the field of implementation science is kind of becoming so rigorous and kind of has so many prescribed evaluative methods. And I think that is at least lending credence to some of the things that, as you rightly said, we love to do anyway. We love to teach, we love to have these programs, and the byproduct really is the research or the implementation science of it all. And I think like that's kind of where I see myself fitting in the academic spaces. I know they have benefit, but if I can show that they have benefit, then I think it has a larger reach.
Yeah, great points, Anna. And I think the signal at your end, your bandwidth at your end might be kind of waxing and waning, because we kind of lose, we tend to lose your voice at times. But just check if you can at your end. So yeah, great points Anna's raised. And so for folks like, so you're talking about like traditional approaches, of course, academic medicine, and you've got to go through the peer review process. But if you're working on newer things and you don't have enough evidence, then don't wait for a publication in a journal would be my suggestion. You could consider a blog or a newsletter or It could be an opinion piece or a perspective piece. And that's what we did as well. I know when way back at the beginning, because we'd done some things, but we hadn't done them recurrently enough to kind of show that there was impact of any kind. But those things were important enough to us, so we packaged it as an opinion piece or a perspective piece. And some journals were interested in carrying those as well. So there was one in pediatrics that we did for pediatric innovation, and some other journals as well. You mentioned intangible benefits, and that's such an important point, because for implementation science, even I think before you can get that solid publication through the peer review process, I think what keeps you going is really that intangible that you're unable to kind of pinpoint it and describe it really well or objectively, but you know that what you're doing, it is impactful, or it's going to be impactful, and you stick to it, and then you start generating evidence as you go along. So I highly, I'm with you, completely with you, where the intangible or intangibles are concerned. Also, you mentioned the soft science of things, or not, so last week, I think maybe 2 weeks back, I forget, but Sata was our speaker, also from Emory folks and from Anna's Department of Emergency Medicine. And the topic we chose for her was narrative medicine. And she's a writer, she's a short story writer. And so narrative medicine approaches are considered the softer side of science. And although it's becoming more evidence-based, I mean, it depends on how you look at things. So definite potential for these kinds of approaches. We've done these over here, and we've learned a lot. So let's get further into like Jugaar innovation, Anna. So like four points that were raised in the chapter was I think was doing more with less, seeking opportunity and adversity, and there was keeping things simple, and I think there was one more which I'm forgetting: thinking and acting flexibly. So keeping maybe a few of those points in mind, whatever you can recall, what has been, what was your experience during COVID-19? Let's say at the beginning of the pandemic, or early stage of the pandemic, while you're working as an EM doc in the US. Retrospectively, do you think you were applying some of these Jugaar innovation kinds of processes? And if you could give us an example, perhaps.
Yeah, I mean, I think we were all doing it all over the world, right, during COVID. I think kind of we were all learning together. We didn't have all the data to tell us what to do, and so we were kind of learning and sharing best practices. And there was a lot of those, like online repositories of people's experiences that became very useful. So we weren't going to the peer-reviewed literature as much. I think some of the innovations that we personally saw were surrounding PPE. So how people would protect themselves, different types of face shields, different things to make PPE more comfortable, like these buttons that would hold the mask so your ears would have a break. Things like that I thought were like very innovative, and things that we hadn't seen before in the same way. I think also in terms of protecting ourselves, so for example, there was concern early on, right, that there could be transmission during aerosol generating procedures. And so like intubation, things like that. And we had actual like boxes built, plexiglass boxes built that would protect the person doing the intubation from aerosol, things like that. And those are all low resource. So I think COVID was actually a time of great innovation. Lots of people came up with a lot of ideas, some that worked, some that didn't. But I think that space, kind of the creativity of humans, was really evident there.
Yeah, great points. Do you think, so you mentioned some things worked and some other things did not work, which is expected. And what is your tolerance of something not working, or failure, in other words? What do you think about that?
I mean, I think it's okay, right? Like that's how we learn. And if you don't, you can't succeed at everything. And so you have to do some trial and error. So I think that all of that is trial and error, and that's how we best learn. So you have to be a little comfortable with it, and no one wants to fail, but also like a negative outcome is still an outcome.
Yeah, great points. And do you feel that, and this question is not specific to your organization, but generally, based on your interactions with folks in the US, EM docs over there, do you think generally the culture is supportive of experimentation? I'm not talking about obviously a well-designed research project, but experimentation is what we're talking about. Rapid prototyping, for example, right? COVID, rapid prototyping, testing. Okay, this works, this doesn't work. What's the tolerance generally in the EM world? Let's keep it maybe relevant to emergency medicine and in the US.
Yeah. I think the EM world is very tolerant of that style of innovation. I think that we're all kind of creative people. EM is so new in the US and new everywhere in the world, right? So that we're all kind of creating this space together. And so I think that that has attracted sort of creative, innovative people, even if they don't think of themselves that way. I think that where the breakdown happens probably is in kind of relating more generally to the field, other disciplines in medicine, where maybe some of these the innovations that we develop or resource back are not quite as well received by consultants, for example, or other people in the space. But I think within our own emergency medicine discipline, I think people feel very comfortable.
Yeah, great points, great points. I think EM is that field that opens up so many opportunities, right, for creating, for innovating, testing things, and so on and so forth, right? As long as you're doing that within a framework of safety, patient safety, and obviously those things are not being ignored. I just, while you were talking, I just kind of realized that POCUS, point of care ultrasound, wasn't that developed by EM docs as an innovation? Maybe
Yeah, I mean,
I
I think
came
the
across something
concept
like that
of it. Yeah.
because of
Yeah,
point
I
of
think
care testing. Yeah,
we have to be at the bedside in a way that many others aren't. And so I think that point of care ultrasound, you're right, is like a really novel innovation that was born out of the need to kind of have rapid diagnosis of
yeah,
patients. And like, look where we're using ultrasound everywhere.
pretty much. Exactly. Yeah. Um, People who are on this call, please feel free to share your comments or questions, and we are happy to kind of get Anna to address those. It's meant to be an interactive session. Anna, I think it's really a mixed bag over here. I don't know exactly who's on this call, but probably medical students, some students, docs as well, and some for innovation folks. There was an interest. I think the residents, the chief resident said that the residents would be interested in talking to you about opportunities in emergency medicine. So, if there are people here who want to ask those kinds of questions about potential opportunities, but just be specific, okay? And I don't think Anna is going to be able to secure a job for you. Maybe she will. I don't know. I'm not sure. So here's an interesting thing about Anna, right? So she worked for the CDC as an epidemic intelligence service officer. So what's that about? What kind of work was that? And was that were there aspects of frugal innovation or Jugaar innovation while you were doing that work?
Yeah, so that is a applied public health training program, which is 2 years after you've graduated from your residency. And basically, I was stationed in our state of Kentucky, which is sort of a state in the middle of the country. That's a lower resource state, so had a lot of needs. And while I was there, I did pretty much any emergency response work in the health sector for the state. So we had a lot of like preparing for influenza. This was also during Ebola, so preparing for returning travelers, a lot of hospital-based investigations, environmental exposures, and even like preparedness for hurricanes, weather events, things like that. And then I was also able to deploy nationally and internationally to help investigate outbreaks on a larger scale. So during this process, I was stationed in Sierra Leone as a district epidemiologist towards the end of Ebola in 2015 there. So that was a very interesting experience. Also similarly worked on yellow fever, Zika, kind of all the big outbreaks that happened during my time there. And I think that while the CDC is a large US governmental organization that has a lot of resources, I think our partners and what we do in the field, it does kind of encapsulate some of that the kind of low resource innovation concepts. And so, for example, what we saw in Ebola, where kind of people created their own, again, going back to PPE, but created their own barriers, their own PPE, their own ways to protect themselves. And even in terms of kind of the outbreak investigation, the contact tracing that happened, it's all about human connection and having those conversations, getting to know people, and kind of gleaning information. It's a little bit like being a detective, which I think probably doesn't require a lot of resources, but just some people skills and the ability to talk and listen as well.
Great. So while you were working for the CDC, and was this before your residency or after you'd completed, or during? Okay, so it wasn't after. And so among all the countries that you visited, I mean, which one's your favorite and why?
Oh, I can't pick a favorite. It's like it's like choosing a favorite child, right? You're not supposed to do that. But I will say I think that it was very formative being in Sierra Leone towards the end of Ebola, where just witnessing the resiliency of the country and how people had really come together and kind of learned from the early horrifying days to kind of be celebratory and kind of share in these like share humanity, even though you can't touch people, you can't, you might still be isolated, kind of what we saw during COVID as well. So I thought that was really powerful and impactful, and I'm so glad that I was able to have that experience.
And did you you've been coming to Pakistan for about 5 or 6 years, you mentioned at the beginning, and so have you been involved in any of the emergency responses, like or disaster responses? Like I think we've had flooding during that time, or I don't think we've had an earthquake during the past 5 or 6 years, but any of those responses that you've kind of led a team?
Not in Pakistan, but certainly in other places. I've done hurricane response work in the Caribbean, and some other kind of response work kind of on this side of the ocean. But in terms of Pakistan, I really view my involvement in emergency response there in terms of preparedness. So I think that by training people in trauma and emergency care, we're, as a world, better prepared to respond to an earthquake, to a disaster, to a humanitarian emergency of any kind. And so I hope that these kind of educational initiatives and collaborations strengthen the field of preparedness in regions and countries and local areas, so that there is less dependency on external support and that there is resiliency, because I think that that's really kind of the future.
Oh, fabulous. I'm just gonna go over to this question. Okay, so Rizwan is asking, hi Anna, thanks for sharing your interesting stories. Can you share any examples of these sort of means or jugaars that may have been taken up by mainstream medical practice, or help them come up with new ways to address any issues in the past or present?
Yeah, I mean, I think a lot of these. I think the field of simulation, I think, is one that has really been taken up in a mainstream way. I've seen it even in my medical education and my career, where we sort of, and I don't know what the sim lab at Aga Khan looks like, but I'm sure it's beautiful and very high tech. But we've seen things kind of swing to the extremes. We have a very high tech simulation lab at Emory as well. But what I see is that these labs are also even uptaking these lower resource like hacks to help train. Like just because you have like an electronic mannequin doesn't mean that still it's the best way to train people. And so as we've sort of created made from what you can buy at the grocery store, I think our sim team is really interested too, and are very happy to implement some of these lower resource hacks. And I've seen these things published in the medical literature, so actually published in peer-reviewed journals. So I do think that that is as that mainstream medical practice is kind of taking it into account some of these innovations, these low resource innovations, and kind of using them to build off, which I think is cool. I think one thing really interesting is 3D printing, obviously not low resource, but the innovations that come from 3D printing, which is now much more attainable kind of in many places, but it's been a cool thing to see that you can actually print a trachea or a chest wall or something like that, that is lightweight, can travel, things like that. So I think it's only going to become more and more mainstream.
Yeah, great points. Okay, so here's another question from Hazik. Thank you, Anna, for this presentation. For your work in Pakistan, can you discuss how you approached getting funding? Was it primarily through your institution or other sources?
Yeah. Funding is like the constant battle, right? So these things don't take a lot of money, but they do take a little money. So I was lucky enough to receive some seed funding through my own institution. So these were small grants that would fund kind of the startup costs and some travel to implement some of these programs. But I'm in my next phase where I really need to kind of expand from there. And I think that that's something that I am personally working on. And I don't know if research grant funding is really the right way to go for me. I don't know that what I'm doing really kind of fills a lot of the needs of those research grants. So I'm looking into other sources. So like kind of donation or industry or philanthropic kind of arms. I think these things fit really nicely with as a potential. So I think that's one thing, or looking at foundations that have a little bit more implementation rather than like rigorous research. So that's, I'm open to ideas. I would love to hear ideas because it's something I struggle with for sure.
Yeah, no, that makes sense. I think we all struggle with that. Where do we find funding that can sustain our work or projects or innovation work, so on and so forth? Oh, cool. There's another question here. Okay, so Rizwan's asking thoughts on peer reviews and research studies done on new or innovative health and wellness market, for example, wearables, practices like saunas and ice baths. How is that seen and viewed in the mainstream medical field? Is that gap bridging? Are mainstream medical practitioners open to these new ways or innovations, in your opinion? It's entirely based on your opinion on this. If you know about, yeah, wearables, perhaps. Yeah, go ahead.
Yeah, no, that I think they're having peer review of some of these things would be very helpful because there's like so much non peer reviewed stuff in social media, news, and websites about some of these innovations, and it would be really great to see some science behind that. So I think that that's where kind of innovation and the old school research publication could really meld, because I think that publishing on some innovation can help jumpstart further innovation. I think like all this stuff, wearables, app-based tracking of different health metrics, things like that, or kind of biometric data, wearables, I think are interesting, and I'd love to know if it's impacting health in a positive way, or if it's just giving us data overload and no one knows what to do with that. For example, yesterday I read an article about, I like to go skiing in the winter here, and they have these like ski boot inserts that will actually like help teach you how to ski better, so there's wearables for all kinds of sports and, and things like that, and they can be very expensive, so it would be great to have like some data behind some of these innovations.
Yeah, that's a great point, and that's a great question, Rizwan. Like while I was thinking about this, even in the US, I guess a lot of these technologies, wearables, they're not necessarily FDA approved for clinical use anyways. It's okay within the realm of wellness, well-being, or health maintenance, but you can't technically be using them and then use that data to guide medical management. Doctors can't do that, and I think there are going to be disclaimers that this should not be utilized for clinical decision making. Although, I mean, that's the intent, that ultimately, I mean, these things would become useful enough. I don't know how many of these actually make it to the to getting FDA approved for clinical usage. Have you come across something? Yeah.
Well, I do like the Apple Watch or other similar smartwatches that track heart rate and rhythm. And I actually tell my patients will come in with their like evidence of AFib with RVR on their rhythm from their watch. And so I sometimes tell my patients, like, if this is a problem for you, like having a watch like that can kind of track some of that from that perspective, that could be really useful. So I think there are some good things, but I think it also is possible to go too far. I was at dinner with a colleague the other night, and he was actually he's non-diabetic, use a continuous glucose monitor to kind of like help understand better his exercise tolerance and some other things. And so I'm like, maybe that, I don't know, that could be going too far. Maybe that's what we should be doing. I don't know.
I have no idea. um,
I have a question.
yeah, go ahead, please.
Yeah, so you talked about being on the field, like being part of disaster teams and all. I just wanted to know, and by the way, I'm a biomedical engineer, so that's where I'm coming from. I want to know how does like being on the field translate into your research or your work that you're doing? Does that
Yeah.
affect anyway?
Yeah, I mean, I think the field really informs everything. For me, I like the research is the primary goal, and relationship building and the education and being in the field informs all that. Those experiences kind of are all low resourced experiences, and I've learned so much from each of those places, like seeing different low resource innovations, whether it's in like how to utilize the ultrasound gel to make the EKG leads transmit better, things like that, like very, very easy small things, to making asthma spacers with soda bottles, things like that. These are things that I see elsewhere, and then I take back and I teach my own residents, and I teach my participants in my courses all over the world. And I learn so much from everybody that I interact with, and I honestly feel sometimes that I'm learning more than I'm giving, which is probably the way it should be. And so I think that kind of those disaster scenarios are really what kind of highlight the most important things, and kind of distill down kind of the absolute needs. And so I think that those are really nice times to kind of reflect and take back from those things and be like, this was what was important and everything else is just noise.
Thank you.
Yeah, thank you for that. Zia has a question. Zia, go ahead, unmute.
Thank you so much. Well, I was just, I wanted to comment, first of all, thank you so much, Dr. Anna. It's really refreshing to see you, and thank you for doing such wonderful global health work in trauma care. And thank you, Dr. Asad, for this wonderful opportunity to interact with her and other people. So I had a player working with Dr. Anna briefly during the COVID-19 when I was a graduate student at Emory. And, I wanted to share a little experience, which is, I guess, relevant with this, with this discussion. We did a little Jugaar when I was, I was looking to get some practicum experience. And Dr. Anna had received a grant, a seed grant from Emory University. And so we worked, because a lot of the work that were supposed to be done was on ground, and during the COVID-19 you couldn't really do all that. So instead we worked on creating a smartphone app, which I supported Dr. Anna's team, and that was very fruitful both for me in my personal career, and I think it was a very good step in terms of the trauma care in Pakistan as well. So really thankful to both of you for doing this talk and working in Pakistan.
I'm so glad that you shared that, Zia. I was going to actually say you should share about what we did. So I'm glad you beat me to it. But yeah, I think that the smartphone app, and we worked with, not a big company. We worked with students and like kind of local app development to keep the costs down, and also who would understand the market best. And so we do have an Android-based bystander trauma care app that is sort of like in its initial prototype. So that's another example. Most people now have access to smartphones, and so having free or low cost resources that aren't wearables or aren't expensive, I think is like a nice bridge, at least from some innovation in an education space to a wider audience.
Yeah, great point. And thanks for that. Thanks for sharing that story, Zia. Zia, what department did you get your PhD, or was it master's or a PhD? And what was your
department? So I got my master's. I'm a Fulbright scholar, so I got my master in public health and epidemiology at the Rollins School of Public Health.
Oh, excellent. And where are you now? Are you working the US, or are you working in Pakistan? Are you here?
Yeah, no, I'm at AKU now, actually.
Okay.
I'm in the community health department. I'm working as a senior instructor there.
Oh, okay. Nice to meet you. I had no idea.
You as well. Thank you.
Thanks for that. Great. We've met somebody at my own organization, at my own institute. Anna, have you been to AKU? Like next time, please do come over, and then we can show you around. We can show you our innovation spaces and our simulation lab.
I've been once or twice, but I'm always so impressed with the campus, and I don't think I've seen simulation labs, so I would love to see that.
Yeah, we could show you that. Based on simulation and innovation, and so innovation hubs. So simulation labs have a specific mandate. Innovation hubs are not exactly simulation. We could call it simulation innovation, okay, but still innovation hubs. Have you experienced innovation through an innovation hub, perhaps? Could be innovation and incubation of a startup, or business incubation of a project that's been taken ahead. And if so, what do you think the role could be of innovation hubs for emergency medicine specifically, where training residents is concerned, or mixed bag of learners, could be nurses and EM nurses and EM doctors being taught together about innovation frameworks?
Yeah, I will say I feel if you asked me a year ago if I was involved in innovation, I would have said no. And I think it's like mostly in like reframing, right? Like when you think about what you're doing, obviously you're innovating. So it is like kind of an interesting space to be in. We do have an innovation hub at Emory. And I think of it as very kind of like formal, in some ways, like formally deployed innovation and incubators, things like that. And I think a lot of what we're doing is like a little bit field-based, kind of on the fly innovation. But I would like to see for my own education as well as for my residents and others, like I think it would be nice to have more crossover between those two, between like the hub-based formal model and kind of the boots on the ground model. And so I think that that would be something I would love to see. And I admit my own naivete in that, that I'm still learning as well.
No, that's a great way of looking at it, right? So hub and spoke model. You've got a more formalized kind of innovation hub, and then you've got boots on the ground. So and there's back and forth conversations happening between the two, and I think that's a very interesting model, by the way. Maybe you could work on it. Happy to kind of facilitate that. Um, yeah, so considering that the book's focuses on not just this chapter, but generally our interest has been on doing more with less. So not having that mindset that, you don't have enough funding, you don't have the right team, you don't have an engineer, you don't have a business person. So how are you going to do these things, scale things past a certain point? So, that we start off feeling limited. So that's not a good place to be in anyways, and especially when you're doing something that's creative and you want to be innovative about something. So I think there was a question in there somewhere, but yes, so a lot of times because we don't necessarily have evidence for certain things and we start implementing, perhaps through implementation science, maybe not in a formalized way, but based on your experience, how do you think one could mitigate the risks or potential risks, because things might not have been tried to the same extent? Clinical research frameworks kind of force you to kind of go through that whole process, and then publish your data, and it's peer reviewed and so on and so forth. Although we've seen papers have been retracted as well after the peer review process, so let's not go there. But from a quick innovation, Jugaar, frugal, fast-track innovation perspective, what do you think could be done, or what things could be in place so that we don't create more problems?
Yeah. I think having kind of a toolkit maybe could be important. So say you want to implement you have an innovation, you have an educational initiative, whatever it is, an app, anything that you had an idea and you're making because that's your passion. I think a toolkit of like, here are kind of the absolute bare minimum things to assess this, to evaluate it. So like a very basic implementation science toolkit that's not overwhelming, because I think for a lot of us, it's so overwhelming to even think kind of about the evaluation phase. But if you implement something without kind of thinking about that on the front end, you've lost valuable data that you can assess. And so I think that that's where a lot of us are kind of scrambling on the back end. We already did the thing and now we want to know if it was impactful, but we didn't get the baseline. So I think like having something like that for people, very easily accessible, examples in there where just do this like quick survey, or here's the tools necessary before you do whatever innovation you have, and that way at least you have some baseline that you can jump off of.
Yeah, great points, actually. Yeah, that's and creating those kinds of, and you've done that through your trauma teams project as well. Created a framework or created like an evaluation or a checklist or something along those lines, right? It's kind of like an audit as well. And
Well, I'm lucky in that actually my colleagues at Indus are so much more forward thinking than I was, and they actually were like, "We got it. Here's all the surveys. Let's do them all before." You know, they really did a great job of setting us up for success and kind of seeing the need for the baseline.
Excellent. So I don't know if you have any more questions or comments, but what do you think about if you look at past the pandemic and where we're at now and where we're headed? I mean, there are a lot of obviously everyone's going through massive issues with the environment and environmental degradation and so on and so forth. So what do you think the role could be of these kinds of frameworks that are quick and nimble, don't require a whole lot of resources, but perhaps to sustain some of these things, yes, you will need more resources, but what role do you see for these kinds of things, and how can we kind of get people? I mean, so the people over here on this call, perhaps including you, we might be a self-selected group of people who are already kind of convinced we're the converted lot. But diffusion of innovation requires you to kind of keep kind of communicating upwards and downwards, and so and an innovation concept or a thought process even doesn't have to be a product or a device, but a process or mindset diffuses into your population. Do you have any tips, suggestions? How can we do this so that more people consider these?
Yeah, I think it's just about continuing to have the conversation and not just having the conversation with those of us on this webinar who probably were interested in the first place and kind of already believe in it, but having the conversation with others, especially leaders, people in charge, who maybe haven't kind of thought about these things or are less convinced, and then kind of continuing to have the conversation, continuing to show impact as much as we can, I think is really important, because leaders and the population, of course, but leaders have a lot of power. And so the more that leadership kind of is into this space, I think the better. And so I think that's kind of just, we have to continue to have those conversations and just with everybody. And I know that you're really great at that. You're always pushing this agenda, which I think is really good. For me, I sometimes struggle kind of to push to continue to have these conversations with everybody. But I think that's important.
Thank you for not like getting upset at me, like, this guy's always going like pushing his agenda. I keep at it. I guess I've been at it for several years now, and I like it. I really enjoy these kinds of frameworks. I was trained as a clinical researcher and a benchwork researcher, but now it's, I think, okay, I've got to implement something before I start writing about it and publishing the data. So there's another question here, and I knew somebody's going to ask about AI. And emergency services of the future look more data-based, efficient, streamlined, and quicker than ever before, while considering the limitations of caregivers and ensuring the needs of the patient. How do you imagine the innovative approach in ED in upcoming years, along with AI and technologies? Great question, Sidra.
Yeah, we're going to see. I mean, the emergence zone is going to totally change based on AI and just even in the last several years, patients like access to their own, for us, we have patients access their own health records like real time. We have an app that texts them like about their wait time and the results and all kinds of things, which people are just getting their information is at their fingertips. I think that's sometimes good, but also sometimes bad, honestly, because it doesn't necessarily have the same interpretation that a conversation with a physician would have. So I think AI can be really beneficial to help streamline this efficiency, but I think we also have to be careful and make sure that it's being implemented in a appropriate way.
Yeah, great. And thank you for being on point. But those are all the important points as to how we're envisioning the emergency department with AI and similar technologies. last question, and then I'm going to hand it over to Zanera. So, as a wrap up, perhaps, or a take home message, perhaps, for our students thinking about getting into innovation entrepreneurship.
I will just say, I think like keep on with your passions, and definitely search out mentorship. I think having mentorship is really, really important to help you kind of grow in your space, even if your mentor is not doing exactly what it is that kind of your vision is, but having people who can support you and help show you a way is really important. And you don't have to have just one mentor. You can have many mentors who kind of help with various aspects of your professional development. So definitely be very intentional about searching out mentorship. And when you're early in your career, I always say yes to experiences early, and then kind of see what fits well, and you can be more selective later on. We're happy to have further conversations if people want to rotate with us or kind of work on projects together. I'm always available. Please just reach out, and I'm happy to chat.
Oh, that's a great offer. So excellent, right? So if anybody is interested, and is it okay if we connect them with you?
Yes,
All right,
please. Yeah.
cool. Thank you. Over to Zanera.
Yeah, thank you so much. And thank you, Dr. Anna and Dr. Said. It was a very insightful session. And I resonated with most of the things that you were saying, especially the mentorship part and the reverse innovation in Jugaar. I think you made a great case for innovation in Jugaar and frugal innovation in LMICs and getting inspired and then implementing it in HICs. Thank you so much. Thank you, Dr. Anna, and thank you, Dr. Said, for your time. Hope you guys have a great day. Thank you.
Too.
Thank
you
you.
for
Thank
that.
you, everyone. Bye.
Bye.
Bye.